Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Podcast. I'm excited to be joined by two colleagues from Johns Hopkins, Dr. Neil Bressler, Professor of Ophthalmology at the Wilmer Eye Institute, and Dr. Kristen Schratz, an assistant professor in the Department of Oncology. And we're going to discuss a hot topic for us, which is adult-onset presentations of retinopathy associated with short telomere syndromes. Welcome.
Thank you, Tim. Thanks for having us.
So Neil, I respect bringing heavy guns with you. So what I think we can do is let's have Neil start a little bit about the two cases that were discussed, but let's then go to Kristen to talk a little bit more about how this crosses specialties and what may be more critical for our patients. So Neil, tell me about your two cases.
The first case is one of those cases that I had no idea what it was. So it went into my folder of, I don't know what this is, and maybe we'll learn over the years. And that's indeed what happened. So the person presented with these multifocal areas of telangiectasis and leakage, a little bit of lipid from it. And I thought, well, looks like a branch vein occlusion, but it doesn't look like a branch vein occlusion. It wasn't at branch points. The leakage was a little atypical on the fluorescein angiogram. And the follow-up certainly was not consistent with that because there were progressive areas of non-perfusion developing, and then these little pre-retinal hemorrhages and then breakthrough retinal hemorrhages without any retinal neovascularization ever noted. Over time, he developed edema. We tried treating it with anti-VEGF, leading to resolution. Over time, he developed some hemorrhage, and we considered maybe we should put in laser to these areas of non-perfusion. But what happened over a longer period of time is he developed multiple medical problems that I'll have Dr. Schratz address, because independent of my seeing him, she was seeing him to identify what was causing these changes that are life-threatening. And then she noted, well, what are these retina changes and could they be associated? So Kristen, maybe you could tell me how you noted him, because then you found my notes in the chart and I found your notes in the chart.
Yes, so he was referred to us in genetics because of a constellation of systemic problems, the most pressing of which was fibrotic lung disease, a scarring of his lungs, but also on top of having liver disease, portal hypertension, and abnormal blood counts and immune deficiency. And so that constellation in our world was very suspicious for a systemic short telomere disorder, which we confirmed based on measuring the length of his telomeres in his blood and then doing genetic testing. And as we were digging through the chart, we noted this long history prior to that of the eye disease.
It's kind of interesting, Kristen, because we see within the retina specialty field, there's a big focus on this in pediatric retina for young infants that are presenting with atypical vascular disease. So what was interesting here is, though we're thinking this is a pediatric disease, lo and behold, you and Neil are bringing in a patient that is older. So this really does span a lifetime for these patients.
And that's what aligned all the findings. We were familiar with these, problems of dyskeratosis congenita, these Coates plus syndrome, which are in children or infants. And some of them have these shortened telomere syndromes. They're autosomal recessive problems that they have. And it didn't connect until finally Kristen said, well, that's what this person has, this shortened telomere syndrome, to actually present in adulthood. And that started us down the path to the second patient.
I think for the first patient is his eye disease was his presenting feature, which was really a decade prior to his more classic lung and liver and bone marrow disease, and really an opportunity for us to pick up these patients earlier.
And Neil, to your point, we're seeing these infants now because we're doing much more genetic screening, and we're not screening for this in particular. This is a surprise many times in an incidental finding for an atypical vascular presentation in an infant. So you only know what you know, and you have to know what to look for. So I find it fascinating that we're seeing the pediatric disease, you see an adult, and Kristen's putting that all together for us from a systematic presentation where this is the first presenting sign. Very, very fascinating.
So Kristen and her colleagues reached out to us to say, well, maybe this can present in adulthood. And we see patients, they're telling us in adulthood, who sometimes say, well, I have some floaters. And they would push that aside, just like we often push it aside. And it got us to thinking, well, maybe these people actually in adulthood are developing some unusual retinal vasculopathies. So we said, send them on over. And it was one patient in particular, which is our second patient, who had some floaters that had been presenting maybe 8 years previous to coming in and then having his diagnosis of shortened telomere syndrome, which was suspected because his father had it. So here we have an autosomal dominant sort of process going on. And when I saw him, he tells me, oh, my father had some unusual retina problem. I said, was he born premature? No. Could this be FEVR, familial exudative vitreoretinopathy? No. This was just very atypical for the features we were seeing, but looked a lot like that first patient, because when I saw this patient that Dr. Schratz and her colleagues had, where they already knew it was shortened telomere syndrome and it was the son of someone who had this, and that person had gotten laser treatment for some unspecified retinal vasculopathy, and unfortunately he had passed away soon thereafter. But the important point, in addition for this patient, was he had the same unusual multifocal areas, retinal telangiectasis, some leakage, little spots of preretinal hemorrhage, as if the vessels were ectatic and bleeding more easily, but not retinal neovascularization. And indeed, he had this substantial lipid, like you see in some of these infants that have these problems. And we said, well, we'll sort of nickname this telomere telangiectasis, because that's what we're seeing. These people with these shortened telomeres having this telangiectasis that at first blush might look like some sort of Coates disease, maybe some branch vein occlusion, maybe some retinal vascular occlusive abnormality, but it's not consistent with any one of those for the specifics that we put in the paper. And it made us think this is really a distinct entity that we might see as retina specialists now, and we need to be aware, because you might have to send it to a specialist in genetics who could look for the shortened telomere syndrome, because I learned from Dr. Schratz, these are life-threatening conditions that these people may have.
I get, we've learned a lot about diseases when our colleagues outside of ophthalmology locate a disease process and then have us see their patients. So are you recommending with short telomere syndrome that these patients routinely have ophthalmologic screening, or are you waiting till they're symptomatic? What's the take home from a non-ophthalmologist perspective?
We are recommending that our patients with very, very severe short telomere manifestations, so autosomal dominant, but on the spectrum still severe. So predominantly the young adults do have routine retinal screening, and we've sent a number to Neil at this point. A few are asymptomatic. Some do have these non-specific eye findings, and I think we're finding a lot of eye disease that otherwise we would not have. We're not recommending screening for all patients, but this subset that have more severe disease.
And what about the correlates? So when I see patients with short telomere syndrome, which for me is typically younger children, should they all be seeing someone in your specialty, or should we wait until they're symptomatic? How do we guide our colleagues?
If the patient has a known short telomere syndrome, they should get plugged into someone with expertise, because we are trying to be more preemptive in management because it is a life-threatening illness. I think not all retinopathy is short telomeres, but if you know it's short telomeres, they should get referred.
And Tim, it works both ways. We are finding that they have asymptomatic patients and who have severe short telomeres, and they're sending them over. And these are young adults, middle-aged adults, and on optos, fluorescein angiography, we're noting extensive changes that are atypical, not typical for FEVR, not prematurity, but are part of this spectrum. And we think they need to send it to us to begin to monitor. We need to send the ones that have this atypical telangiectasis to them to look for shortened telomere syndrome.
Well, until we knew there was shortened telomere syndrome, no patient had this disease. So it's kind of interesting that we are now, at least within our pediatric field, seeing so many patients, more than we had ever appreciated. So I'd like to thank both of you, Dr. Schratz and Dr. Bressler, for joining us. I think that our listeners are going to have a great introduction to short telomere syndrome for that and have a little bit of take-home pearl as to what to do with their patients. So thank you both very much for your time. Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.